Ladies and gentlemen, the program is about to begin. Please take your seats. Please welcome Foreign Policy Executive Vice President Allison Carlson to the stage.
Hello, everyone. Good morning, good afternoon, good evening to those of you who are joining us online and from around the world. I'm Allison Carlson. I'm Executive Vice President here at Foreign Policy. And on behalf of everyone at FP, I'd like to welcome you to our 2023 Global Health Forum. It's great to see many of you joining us and many fans of FP. I see so many familiar faces around the room for what promises to be an enlightening day of conversation that's really dedicated to strengthening global health systems around the world. Now, we've gathered here today because global health, in addition to it being a humanitarian issue, is a critical component of foreign policy, international security, and economic stability. Now, the events of the last few years, and notably the COVID-19 pandemic, have exposed weaknesses in the global healthcare systems, highlighting an urgent need for reform, investment, and capacity building. And even as we're emerging from the pandemic, it's still very present in many places around the world. And this is among complex challenges, including economic instability, climate change, and shifting demographics. But in the face of these challenges, there's a need to develop sustainable solutions that can withstand complex crises in an ever-changing world. And this forum today is an opportunity to do that and to really engage with leaders who are really working on the front lines to address many of these challenges, and to discuss how investments in health can really ultimately strengthen resilience and stability around the globe. In addition to the speakers who will be on stage with us today, many of you in this room and in the audience are practitioners and experts yourselves. So this is a welcoming for all of you to discuss, engage, and deepen your working relationships together. So, thank you for being here with us in person, and thanks to the hundreds of people who are joining us online from around the world. You can join the conversation, particularly those online, using the social media hashtag FP Global Health Forum, and we encourage you to contribute your thoughts there. And for those in the room, you'll find some flyers on your tables, and you can use those QR codes to access the agenda and to submit questions. We really want this to be as engaging and interactive as possible throughout the day today. So thank you again for joining us, and let's dive in. So for our first conversation, I am absolutely honored to welcome Lady Rosalyn Murata, the chair of the Global Fund, and Gail Smith, CEO of One Campaign, for a conversation that is really going to frame today, looking at some of the challenges ahead and the progress that's already being made. Welcome. Thank you both for joining us today. We are absolutely honored to have both of you. And Lady Rosalyn, thank you for joining us from the other side of the world. She's joining us today from Queensland and Australia. So thank you for taking the time. I know it is quite late there, but really appreciate it. And let's kick off. And as I mentioned, this is a perfect conversation to frame the day today, and just delighted to have both of you. And Gail, I'd like to start with you. So a few years ago, at the request of the Secretary of State, you were asked to become the coordinator for the global COVID response, and really focusing on health security around the world, including in low and middle income countries. And so, sitting here today and reflecting back upon the last few years, what are some of the lessons learned and some of the vulnerabilities that were really exposed in our global health system from your perspective?
Sure. And it's great to be here, and thank you for doing this, because this topic is so important, global health across the board. Look, I think one of the big lessons, and this is an obvious one, but I'll state it anyway, because I think it was the biggest constraint, is that politics trumped science. And so in comparison to the Ebola epidemic, which I was also involved in, it was much harder. I think also because the world failed to come together in the way we might have anticipated. So I think we learned a lot about what needs to happen on the political diplomatic side to make health interventions effective. On the other side, I think we learned a number of things. One, that programs like PEPFAR, like the Global Fund, in addition to carrying out their missions, have been part of building some of the foundations of the infrastructure that was needed to respond to the pandemic, which both made clear the kind of byproduct, a key impact of these programs, but also reinforced the fact that we've got to do more to build those systems so they're fully resilient, because we did see things like huge stresses on the healthcare workforce. So I think that was a positive and a signal for what needs to happen next. And I think the last thing that we saw was how exposed we all are in terms of global health security. And there's been a bit of a cycle here. After the Ebola epidemic, there was tremendous interest around the world in building that capacity. And it lasted for about 18 months. And then people were like, oh, Ebola, that was a long time ago. Now, post-pandemic, I think everybody's kind of tired of the pandemic. It's not something I want to spend a lot of time on. But now the same question remains in front of us. Are we going to reinforce those investments that we know are so critical and build back the losses that we saw during the pandemic?
So many important points there about politics and how to overcome that, especially as we think about funding and reauthorization and continuing the funding that's needed. And I really want to come back to this question about investments in just a moment. But first, I'd like to turn to you, Lady Rosalyn, and from your perspective, and also from the Global Fund and your work on, Papua New Guinea and other parts of the world, how are you thinking about lessons learned from the pandemic? And as you reflect, what are some of the vulnerabilities that really stood out that are now priorities for investment?
Thank you very much, Anne, and thank you for inviting me to join this conversation today. From my perspective as chair of the Global Fund, I think one of the main issues is that partnerships like the Global Fund provide important lessons and play a pivotal role in promoting global health and fighting pandemics. And the history of the Global Fund shows that. We've invested over the last 20 years around $55 billion in over 120 countries. saving 50 million lives and reducing the death rates from the 3 diseases by more than half. So money does work, as Gail pointed out. But reflecting on the impact of COVID, it's clear that there are huge gaps that need to be addressed. The pandemic exposed the vulnerabilities and inequities in the health system, supply chains, vaccine and commodity distribution systems. We're reminded of the fundamental importance of community and public health systems in the global response and the urgent need for investment, international coordination, and system reform. I think some of the main lessons are that, firstly, we need to consider the wider economic and societal toll of infectious diseases. Last year, the IMF estimated that COVID will cost the global economy $12.5 trillion through 2024. But infectious diseases like HIV, TB, and malaria also have huge economic costs. Secondly, we have to make the economic, societal, and human threat posed by infectious diseases visible to policymakers and the private sector. This is really important for guarding against complacency. It's also essential for mobilizing the necessary resources for prevention and mitigation. The third thing I would say is that we need to keep in mind that the costs of responding to outbreaks far exceed those of preparedness. And hence, we need to emphasize the imperative of prioritizing health in budget allocations and recognizing the long-term economic benefits of investing in global health. And finally, I think COVID showed us that we do have many of the tools and solutions needed to combat infectious diseases. It's a political choice whether they will be funded and utilized or not.
You raised so many important points about the cost of disease, the cost to communities, cost to economies, and our research division, FP Analytics, actually had done some research specifically on returns of health investments to societies, to communities, to economies as well, in collaboration with the Global Fund. And I'd recommend everyone to check that out. I believe those online can access it now. But it is so important to think about what are those returns on investment for public health, especially when the costs are cascading and so much greater, and what more can be done upstream for those kinds of investments that will have direct impact. And so in light of the investments, and as you mentioned, sustainability, long-term commitments, you mentioned PEPFAR. So I'd like to turn back to that as an example of sustained funding and impact. So from your perspective, with the emergency plan for AIDS relief, over $100 billion has been invested over the last 20 years and the 20-year anniversary. So from your perspective, what more needs to be done to finish the job? How has that funding impacted lives and livelihoods, and how can that be sustained?
Look, PEPFAR is one of the greatest stories there is to tell on global health. And there are 25 million people today that PEPFAR has played a prominent role in saving the lives of. That's 25 million people. Equally important, if you think about how the COVID-19 virus spread around the world, imagine if HIV had gone unchecked. I mean, if we look back at what was happening when George Bush announced PEPFAR and the Global Fund was then established, that virus was completely unchecked. And the damage that it would have done to entire societies, to economies, I would wager would have been equal to and probably far greater than what we saw with COVID. So I think it's a matter of saving lives, but it's also preventing a catastrophic, what would have been a catastrophic pandemic. I think the secret sauce in PEPFAR's endurance has come from a number of places. It's been bipartisan. In fact, I would say it's been nonpartisan. There were Republicans and Democrats who supported it. If you were around then, you might recall that Democrats had some issues with George Bush, not on this. Republicans had some issues with Barack Obama, not on this. And there was a continuation of that bipartisan consensus that this is something terrific that America is doing. And that's been one of the things that has fueled the sustainability of PEPFAR financing. The second thing has been results. The results are extraordinary. They're measurable. This is one of the things in global health that helps any of us who are advocating for an expanded role for the United States around the world or increases in foreign aid. You can measure and capture the data to show the real impact on lives, but also on the trajectory of that virus. The third thing is, if you say you're going to end an epidemic, which is what President Bush said, it's really problematic if somebody decides to stop. You can do that. But the stakes, you're going to stop people receiving antiretrovirals? You can't, I think the costs of inaction are fairly dramatic. So I think it's a great story. What needs to happen to sustain it? We got to be careful about saying, oh, it'll only take X number of years and the epidemic we'll be able to reclassify it and not call it an epidemic. Because many things can happen, but I think we have seen enough progress to know that this is a fight that can be completed and a virus that can be managed and people can live with it. We can't ever withdraw entirely. So I think we got to keep our eyes on that prize, make sure the funding is sustained, because dips in funding, whether it's for PEPFAR or the Global Fund, have a huge impact on the trajectory of the virus, and nurture that nonpartisan consensus. I mean, there's not a lot of agreement in this city between parties, like on anything. But on this one thing, for a lot of reasons, and thank goodness it's happened, people have risen above politics to say this is something we can get done. And it's a spectacular story. I'll just finish by saying, when I left the Obama administration, in those last days, you're like, oh my goodness, there are all these things you wanted to get done, and you're racing around. And one of the thoughts we had was that at some point, PEPFAR, which is the President's Emergency Program for AIDS Relief, it's President 'S, that given the bipartisan support for PEPFAR, there was a brief interregnum in there, I'll let you figure out who that was, but the sustained bipartisan support is, eventually that should be called the President's plural. Because George Bush started it, Barack Obama expanded it, Donald Trump didn't, but Republicans and Democrats on the Hill joined together to make sure the budget was sustained. President Biden's right on it. It's a great story.
It is a great story, and a great story of U.S. leadership in that regard as well, and what is possible.
Well, exactly.
And so thinking about the Global Fund, and also collaboration internationally. Lady Roslyn, when you're thinking about the need for sustained funding, how are you thinking about that? And you mentioned partnerships. What are some of the conversations that you're having on an international and global level about the need to sustain funding? And what are your priorities in those conversations?
Good question. We're having lots of conversations. But first of all, I want to also acknowledge the fantastic contribution of the US government, both through PEPFAR, but also as the largest donor through the Global Fund. You'll recall that last year, President Biden hosted our seventh replenishment, where we raised a record $15.7 billion, and the US itself pledging $6 billion for the 3-year cycle. So a fantastic commitment both to PEPFAR and to the Global Fund from the US. But at a global level, I think one of the important things for the future is that we need to place global health within what's happening today, within the climate debate, within the debate on economic uncertainty generally. We need to navigate competing funding priorities, at the same time advocating for sustained investment in health. And these are the sort of conversations we're having with many organizations, And the Global Fund, we remain absolutely focused on HIV, TB, and malaria, but we need to look at the relationships of those diseases to the other issues of the day, particularly to climate change and conflict.
Absolutely. And, obviously these are global challenges, but it's very important to focus on the last mile for health delivery and local impact. And so I'm curious how both of you think about that. And with the One Campaign, for example, how are you translating what is a global action and movement into local impact?
Well, I think one of the things we did during the pandemic was something called Pass the Mic, where we had a lot of very influential people, some artists, actors, writers, with huge social media followings who turned over their platforms to experts. So we had real people who actually knew about COVID, but including some frontline health workers. And I think part of the storytelling that needs to be done to keep this alive is, I think, in the space of HIV and AIDS, telling the stories of babies that are born HIV negative and the millions of those, telling the stories of women and men who have survived and are living healthy lives. That kind of tangible storytelling works. But I think there's another story we need to tell, and it gets to some of the points made on how this is connected to the economic upheaval we're living through now and the damage done by the pandemic, climate change, and everything else, particularly low-income countries, is the story of the frontline healthcare workers. Just like in the United States, and what we all saw here, these were the game changers. These are the one part of the sort of human supply chain that we could not do without, who took the greatest risk day to day, who put their lives on the line, who were there when families and neighbors couldn't be there. And that community was put under severe stress. It is underfinanced. It is not large enough. And I think we need to tell that story because as part of sustained financing, I think we need to more deliberately invest in health systems and what's called health system strengthening, which is somebody who volleys back and forth between government and advocacy. I can tell you the most exciting public campaign in the world is not like health system strengthening now. It's like, but after the pandemic, I think people recognize that if you've got that strong foundation, and again, we saw that in every country, we saw that across this country. If we have that strong foundation, you are better served if there's a health crisis. Your kids are going to be healthier. You're going to live a longer, healthier life. So I think telling the stories of the foundations, if you will, the capacity that's been built, that needs to be built, the things that were done. I see a friend of mine from the Ebola team here. During the Ebola epidemic, to build lab and other capabilities, we've got to tell those stories and make those investments, because that's the foundation and the resilience that is going to enable countries over time to more independently manage their public health.
Absolutely, and I really appreciate the underscoring of the importance of the healthcare workforce and the need to invest in those who are on the front lines grappling with this day in and day out. We do have an audience question that I'd like to bring in, and we're almost out of time, but please continue to submit your questions here in the room and those who are online as well. So my colleague Claire will read the question.
Unfortunately, it's a rather long one, so I'm sorry to ask it at the end of the segment. But my son from Newfoundland is wondering, my question is on partnerships for global health, as this is a phrase that comes to the top almost every time. I want to ask the speakers, how? Bring 5 people into a room, and that's a challenge, let alone people from more than 200 countries. What are your thoughts on some of the best mechanisms for partnership and the best practice models?
Great. I'd love to turn that over to you, Lady Roslyn. You mentioned partnerships at the outset. And so the question is, what are the mechanisms? How can we forge those partnerships more effectively?
Yes, thank you for repeating the question because I didn't actually hear it. One of the things about COVID is that for the first, I think it really did help global health agencies to work together better. They were forced to. And that set a foundation that I believe is continuing. Agencies are now much clearer of the need to work together. The Global Fund has always been a partnership. It's a partnership of governments, of civil society, of private sector, of donors, of people living with disease. And maybe the area we've got to work more on in the future is how we interact within the total global health architecture. Not easy. Everyone is used to doing things their own way, but people did cooperate during COVID, and it set a very good example for the future, I think.
Absolutely. And Gail, I'd like to turn to you for a final thought on partnerships and bipartisanship.
Yeah. I think one of the additional points, and I agree with what's just been said on partnerships, is always maintaining the partnership and collaboration between the health experts. And even when there's not been political cooperation among governments, it's most often the case that those connections remain, and they're vital because those are the experts. I'm not an expert in Ebola or HIV. Fortunately, I had some colleagues who are and were. So that's a partnership that is, quite frankly, a little bit more intact than the political partnership that we should have. I think on bipartisanship and building partnerships, a couple things to think about. One is that sometimes when you get into a room with somebody you disagree with, or somebody who comes from an entirely different line of work or background, and you can agree on something, even now, something starts to happen. It gave me enormous satisfaction during the Obama administration to work with the previous head, with Mark Dybul, who had set up PEPFAR, and we joked all the time that everybody thinks we all hate each other, and here we are, because there was something bigger than ourselves. So I think remembering there's something bigger than ourselves, and all it takes to make a difference is to find one thing you can agree with somebody on. And if you're a nonprofit and you can agree with a company that this is your role, that is their role, and together you can move the ball forward, take that partnership and build it. If you are not a religious person and you're partnering with a person of faith, whatever drives each of you to be in that room is sufficient. You're in the same room and you can do it. So I think, particularly in highly politicized times, you just got to put some of that away. There's plenty of time and space for that. And focus on what it is we're trying to do, which is make the world better for everybody.
Absolutely. And underscoring the connections between science and policy and industry and impact are so important. And we have so many people in the room today who are experts, policymakers, practitioners, advocates, and others. And so your point is so well taken, and appreciate both of you framing the conversations for us today and also for the ongoing work that you're doing. Really appreciate you being here. Gail Smith, CEO of One Campaign, Lady Rosalind Murata, all the way from Australia. Thank you for joining us, and thank you again for your work.
Sure, thank you. That was fun.
Thank you. That was fun. Thank you.
And now, please turn your attention to the screens for an interview featuring Director General for the International Federation of Pharmaceutical Manufacturers and Associations, Thomas Cuny, and Vice President of Research for FP Analytics, Dr. Maisha Alam.
Well, it's now my pleasure to be joined by Thomas Cuny, the Director General of IFPMA. Thomas, thank you so much for being with us today.
Very pleased to be with you.
Let's dive right in. I wanted to ask you first about the issue of equity when it comes to access to medicines. Now, the negotiations for the new pandemic treaty have generated debate about ensuring equitable access to future medical products and services across the globe, including not only in high and middle income, but also, of course, low income countries. So let me ask you this. How is IFPMA thinking about and working to prioritize equity in the treaty language? And how can we prevent gross inequities when it comes to PPE, therapeutics, vaccines, and other essential goods that emerged during the COVID-19 pandemic?
Basically, when we look at lessons learned from COVID-19, I think innovation delivered, access to pathogens unhindered was not due, partnerships worked, but equitable rollouts didn't work as it should have done for a number of reasons. We need to make sure that in the pandemic treaty, we do not compromise what worked well. The ability to innovate, the fast response, the access to pathogens, but we do need to focus on equity. I see basically two avenues in terms of doing that. One is we have multiple initiatives for geographic diversity of manufacturing, in particular in Africa. Because of Prime Minister Modi shutting the border from one day to the next, didn't get the vaccine which COVAX, the partnership, had ordered from the Serum Institute of India. Therefore, we need to engage on better diversity of manufacturing, but that will take time. You do need the skilled workforce. You do need the functioning, strong regulatory system. You need sustainable demand in markets. And because that will take time, we also need an immediate fast response. And that's where we from the industry have joined forces with developing country vaccine manufacturers, but also with bio. And companies are committed to put aside part of real-time production for use and allocation by global organizations to people in low-income countries. The so-called Berlin Declaration, which we signed up to in June last year. I think that's a very down-to-earth pragmatic approach, but it will only work if the countries with manufacturing capacity allow exports.
Well, let me pick up on a couple of things that you just mentioned. Certainly the point about diversification of manufacturing and about regionalization are all really well taken. But there's also a related issue, I think, that's relevant here, and that's about intellectual property rights. So how would you address concerns that the pharmaceutical industry's stance on intellectual property rights may in fact impede global preparedness for future pandemics? And how do we achieve a balance between protecting intellectual property rights and addressing urgent health crises?
I beg to disagree. When we look at how innovation delivered, it was really on the basis of an old framework of partnerships. For example, last week in Geneva, we hosted a workshop on voluntary licensing and technology transfer, where we had pairs of innovators, licensors and licensees from generic companies, developing country vaccine manufacturers. Each and every one of them, whether it's from South Africa, from India, from Latin America, from other parts of Asia, of the recipients, they emphasized this was based on knowing each other, on partnerships which had started years ago. It was based on going far beyond, the license of a patent which you can use, because know-how sharing, educating skilled workforces, helping companies to do the clinical trials. That's something which you really cannot coerce. And when you look in, for example, the vaccines field, mRNA vaccines were developed on the basis of 30 years trial and error, mostly trial and failing in oncology, and suddenly you had a breakthrough. This would not have happened, most of it, by the way, privately funded, risk funded. And the companies who came up, with the vaccines, tests, and treatments, who got us out of the pandemic, they signed up in more than 500 partnerships. My experience goes back 35 years. I've been involved in HIV/AIDS, actually exiting, pushing the industry to exit the lawsuit with South Africa. I've seen the debates about swine flu, about bird flu, where the issue of inequitable rollout was actually much worse than what we saw during COVID-19, undermining, the system which led to the innovation, where, for example, more than 60% of the treatments used against COVID were repurposed. Companies looking into products they already had in use for patients where you could use compassionate use. All these voluntary partnerships would be jeopardized if you would enforce a waiver on patents. And it was interesting for me to listen to the generic manufacturer and the vaccine manufacturers from developing countries. Each and every one expressed concern about sustainable demand, about unlicensed competitors, about substandard counterfeit competitors. And each and every one of them, actually unsolicited, said the partnerships which we had were great, and they were voluntary, and they were built on trust, built up over years.
That's really interesting, and I think leads nicely to the next thing I wanted to ask you about. And you were mentioning swine flu and bird flu and a variety of other diseases that have led to multidimensional challenges, and in particular when we think about access to pathogens. The idea of countries having sovereignty over their genetic resources, including pathogens, is also a contentious one. And so let me ask you this. How should the global health community reconcile the need to share data on emerging pathogens in a timely manner with concerns about national sovereignty or potential financial benefits?
To be honest, there's a deep flaw in applying Nagoya access benefit sharing principles coming from the Convention on Biodiversity to pathogens. I must say, everyone I talked to on COVID-19, the issue of ABS, access benefit sharing, of benefiting or taxing companies who actually came up with the goods simply didn't occur. Whether it was from China, from South Africa with Omicron, from Brazil or other countries, scientists share, because this is very different from the biodiversity where you want to protect the richness of the fauna and flora. The Amazon rainforest is unique in the Amazon. Pathogens, number one. I haven't come across anybody who talks about need to protect the diversity of pathogens. You basically want to contain them, you want to eradicate as much as you can. And the benefit from sharing comes from the vaccines, the treatments, the tests developed. And also the ubiquitous. Omicron, if Dr. De Oliveira from South Africa would not have shared them with the GISAID data bank, it would have taken about 48 hours maximum before Omicron would have been sequenced in the UK or the US. Therefore, this is very different from CBD. The one point I really strongly agree, we need to come up with a solution to equity. We need to avoid the transactional model, which would hinder, delay access to pathogens, which would complicate the response which we have now. But we need to come up with a solid response on equitable rollout.
I really appreciate that last point, and thank you for bringing that up and giving such a comprehensive take on that issue. Before we wrap up, I want to definitely ask you also about the anticipation of and mitigating the risks of future pandemic threats. I know this is something that you are continuously engaged on, and something that I think is on the minds of many leaders in the global health community, in the international security community, in the development community. And obviously, this is a topic that's been on the agenda of the World Health Assembly this year, will be on the UNGA and elsewhere. So let me ask you this. While the COVID-19 pandemic has been declared no longer a public health emergency by the World Health Organization, experts have emphasized the importance of preparedness for future pandemics. And so how does IFPMA envision its role when it comes to pandemic preparedness in the coming years? What actions is the organization currently taking or planning to take to mitigate these threats? And how are you trying to make the most of the inter-years, so to speak, between pandemics?
I personally believe, and I believe, that we need to start now when COVID hit the world unprepared, ill-prepared, and even some of the strongest healthcare systems in the world, but it's France, Italy, UK, US, they suffered, from the lack of PPEs, the lack of preparedness. Therefore, we can't afford to do the same again. With that, looking at COVID, the ACT-A partnership was sort of building the plane while we were already on air, flying. Therefore, we really need to subscribe to this multi-stakeholder inclusive partnership with private sector at the table during the interim time. And then I see actually I'm pretty encouraged and feel optimistic. We see companies, for example, teaming up in pre-competitive research on antiviral, the Intrepid Alliance. We have partnerships with CEPI, the Coalition on Epidemic Preparedness and Innovation. We have a company, for example, agreeing with CEPI to work on prototype vaccines of priority pathogens. Before you know whether one of this will lead to it, we are involved in the 100-day mission. The first vaccine made it in 326 days from declaring of the pandemic to Margaret Keane getting the first jab in the arm in the UK. The aim to do this in 100 days is only possible if regulators who work 24/7 during the COVID pandemic look into what could we do even faster. If companies actually already prepared in terms of scaling up, in terms of addressing pandemic threats, and we need to increase surveillance. We need to strengthen surveillances, and last but not least, we need universal health coverage. We need to have country readiness, because by the time we had sufficient vaccines, the big problem was the nurses, the doctors were not there, vaccine hesitancy was a problem. We need to work on all of this now, jointly, multi-stakeholder partnership.
Thank you. That last point about universal health coverage and how UHC and pandemic preparedness are in many ways inseparable, I think is so important and often overlooked. So I really appreciate you underscoring that point. Well, Thomas, it's always a pleasure to be with you. I appreciate you making the time and your leadership. Thomas Cuny, Director General of IFPMA. Thank you again.
Thank you very much.
Next up, please welcome Director of the Influenza Division with the Centers for Disease Control and Prevention, Dr. Vivian Dugan, Professor at Johns Hopkins Bloomberg School of Public Health, Dr. Andrew Pekoj, and Vice President of North America Commercial Operations for CSL Seqirus, Dave Ross. This conversation on influenza strategies in the age of COVID will be moderated by Maggie Lake, veteran journalist and founder of Maggie Lake Media.
Everyone, good morning. It's so nice to see everyone and excited to talk about this. We were all just chatting for a moment outside, and I said, oh, it's summer, we can relax, everyone's focused on the beach and vacation. We're not at all thinking about pandemics and flu, but they all are. That's their job, is to worry about it and think about it strategically ahead of time to help protect us all. So we're going to be talking about influenza strategies, flu strategies in the age of COVID, really in the wake of what we went through with the COVID pandemic. But Vivian, I wonder if you could kick us off and just sort of set our expectations. What are we anticipating? What are you tracking for the coming flu season?
Sure, that's a really great question. I think it's twofold. A lot of the work that we do at CDC is part of seasonal influenza surveillance. And so we're tracking and checking and making sure that we know which viruses are circulating in the US and globally each year. But that serves as an exercise for us for being prepared for pandemic influenza as well. So pandemic influenza can start anywhere in the world. These are often viruses that come out of the animal populations, wild birds and swine, and can make people pretty sick. And so I think that as we are ready for seasonal influenza, we had a pretty robust season this year in the US with the co-circulation of COVID-19 and RSV. We are watching what's happening around the world in the Southern Hemisphere to make sure that we are ready for whatever may happen in this coming season in the fall and the winter months.
So do we anticipate it's going to be worse? Do we know yet? Are we able to sort of forecast out what we're expecting?
Yeah, it's really challenging. You know, I think if you've seen one flu season, you've seen one flu season. This is one of our many sayings in the flu space. You know, we don't know. We do watch and analyze what's happening in the Southern Hemisphere quite a bit. And so we're seeing activity in Australia, several other countries like Bolivia, Indonesia, as well as Chile that have started in earlier, a couple weeks to months earlier this year. And so that could be an indication that we may have an early season, but there's a lot of factors that play into this, from population immunity, available vaccination. Viruses change. You know, when we think about flu, it's not just one virus, it's actually 3 to 4 viruses each year that circulate around the world. And so it's always flu season somewhere. So in the Northern Hemisphere, it's our winter, but right now it's winter in the Southern Hemisphere, and so that activity is starting to pick up.
Yeah, and as we know, we are all back on planes, traveling, sort of catching up with everything we missed, which is fantastic, but also probably means that we're going to see a lot more people moving around the world and circulating, which probably raises the risk. Andy, how does this plug in now, or how are you all approaching this and thinking about this in the wake of the COVID pandemic? Have we learned things? What are the lessons coming out of that may apply when we think about flu pandemics?
Yeah, I think that the most compelling thing was understanding how quickly we could gear up and rev up and increase our capacity to do things given the resources. Certainly with COVID-19, we went from virtually nothing to being able to do at Johns Hopkins thousands of tests a week over the course of a month. And we can do the same thing with influenza if that's needed, if that's necessary. But it's also about preparation. As Vivian mentioned, there are lots of different flu strains out there, making sure that our testing is in place to recognize each of them effectively, making sure we don't just test, that we have the follow-up strategies in place to be able to treat people or give people the appropriate advice when they are infected. And I think the other thing, too, is understanding that influenza season is also respiratory virus season. And people are infected with lots of other viruses potentially at the same time. And we now understand that we can actually gear up and be able to maybe test for lots of different viruses to give people more information about what they're sick, as opposed to just the, I'm feeling sick, but I'm COVID negative, so off I go.
Yeah, well, this raises a really interesting point, doesn't it? Because it's kind of changed how we think about it, because especially in the early days, the severity of COVID-19 and your concerns about it, your concerns about spreading it to vulnerable members of your family. In the wake of that, everything else seems like, well, it's not going to kill me. So that's a challenge as we move forward.
Absolutely, yeah. And flu could be very, very devastating.
Right.
In some of the worst years, you could see over 40 million people sick. You could see 700,000 hospitalizations and up to 50,000 deaths. So it's a really, really significant virus, but it does kind of get muted out by all the last couple of years in the pandemic that we had to manage through. So, you know, it used to be that flu owned the fall for yes. immunization, yes. and now there's a challenge where flu has to share with COVID immunization and prevention, and now potentially RSV is also going to be something that's immunized probably at the same time. So it's been a very interesting story around flu. You know, people think of it as kind of a very stable environment, but if you look back over the last decade or so, there's been tremendous advances in recommendations, moving from condition-based to universal recommendation, changes in access points around retail, new vaccines being launched that provide better protection. So the decade before the pandemic, there was a general improvement in immunization rates and protection. Pandemic hit, and obviously it had to take priority, and luckily we now know that flu was very little flu activity, so we were able to focus on COVID at the time. But we've gone from the peak of immunization for flu just 3 years ago to now we seem to be in a drop in immunization rates. So we're competing with just fatigue that's out there. We've got changes in the access points. You know, we were just talking at the just before coming on that, what is driving the lower immunization rates for flu? And one of the things we have to look hard at is access points. So many people got immunized at the workplace, but not as many people are returning to the workplace. So where are they going to go for their immunization? So working with health authorities, with the physicians, the immunizers, the pharmacists, and the industry, we have to figure out how do we get this track back in the upward direction of increasing immunization rate, because the consequences can be very, very severe for flu.
I think you said a lot of things there, and I want to unpack all of them. You mentioned something about the improvements. I think you said condition versus something else. For those of you who are not as deep in this, what do you mean by that?
So at one point, immunization recommendations for flu were based upon condition-based recommendations. So did you have a weakened immune system? Do you have some underlying medical condition, like were you a diabetic and therefore recommended for immunization? It was then learned that trying to screen for those types of patients was difficult in a very short period of time. So the CDC went to an age-based recommendation where it was everybody 6 months and above should be immunized. So now if you walk in, if you're 6 months or above, you're recommended for immunization. And that made access much easier, and it made the immunization rate, increasing immunization rates.
Lowered the bar.
Yeah, lowered the bar.
To figure out whether you were eligible or not.
That's right.
Vivian, the fact that so I don't know that that a lot of us realize that the immunization for flu sort of fell off the cliff, it sounds like.
Yeah, during the first year of the pandemic, we hit the high of about 172 million people immunized. Last year, it's estimated that less than 140 million. So there's been over a 30 million dose drop-off in immunization.
Which is understandable because we weren't leaving the house. So it wasn't as much of a concern. It wasn't as prevalent. We didn't see it. Vivian, that's got to be a concern based on what you just said we're expecting, and which sounds like there's a lot to be concerned about, and yet we've got to claw back all those immunizations.
Yeah, no, that's completely spot on. All vaccinations, especially childhood vaccinations, really dropped off during COVID-19. But for influenza, we are seeing significant drops for pregnant people for influenza vaccine, for those with underlying conditions, which make them, again, at higher risk for hospitalization and death. And so those very immune compromised or vulnerable people, very young children, are at the highest risk for any type of severe outcome. But then we're also seeing, of course, a lot of the same kind of mirrored changes that we've seen with COVID-19, where we've got health disparities and health inequities that are happening in certain populations, where access seems to be one of the reasons why we're not getting shots into arms for influenza, as well as an increasing change in disparity between rural and urban communities. And so in thinking through all of this, part of our campaign at the CDC for influenza vaccination this year, it's our third year performing this, is to really focus on reaching those individuals to try and get those numbers up. So not only for parents who have children aged 6 months to 12 years, but also for those who are at higher risk, kind of those underlying conditions, immunocompromised, as well as health disparities, so Black and Latino populations, and then of course that rural and urban populations, to really kind of bring those numbers up.
Both Andy and Dave, why are we seeing those disparities? Because looking at it from a layperson's point of view, I felt like so many of us got pulled into systems because the COVID vaccine in many cases was mandatory. So we were reaching into pockets of people and figuring out there were mobile. I still see, tents up in New York City still to this day. Many, they're very few and far between, but they were on every street corner in major cities. You would think that more people would now, that infrastructure would be created where more people would have access. Why are we still seeing disparities? Andy, let's start with you.
I think it's critical to understand that communication has oftentimes been an underlooked part of the messaging around vaccines, and understanding how to communicate to vulnerable populations, to different populations effectively, is something that we haven't really invested enough time in. It's certainly one thing when you say it's mandated, then people line up, and even if there's a little bit of hesitancy, they'll usually line up and get their vaccine if it's mandated. But as soon as you take that mandate away, it falls on the communication part of it to make sure that people are not only understanding the benefits, but that you're communicating to them in ways that resonate with them, through the right channels, through the right people and individuals to get those messages across to people. And again, I think we've always sort of known that that was an important part of the communication process, but I think now we're really understanding how critical it is to get to some of these populations that are normally under-vaccinated.
And I think adding to that, there's some structural things that have changed during the pandemic. I believe the number is something like over 300,000 healthcare providers have left that industry. So there are over 300,000 fewer healthcare providers out there. So the strain on the system is greater. I think that there are some challenges around access points. We're still trying to figure out what does the workplace look like, and where should we go to get immunization. It's been disrupted more through this pandemic than ever before. So I think there's a settling out there. And I think, unfortunately, because of the politicalization of vaccines, it's making the conversation between the healthcare provider and their patients more difficult. So where we know that historically, that 80% of the time, if you get a firm recommendation from your healthcare provider, the patient's going to follow it. I think the healthcare providers are a little bit more hesitant to be firm, especially when it comes to vaccination, because of all the debate that's going on around the mandates and how the COVID program was implemented, at least in some people's minds. So I think they're less likely to engage in the same way they did. So these are all challenges that we have to identify and then start chipping away at them one by one so that we can start changing that direction.
And you mentioned conversation. That's if you're having one, because of the nature of the changes in the infrastructure, which I think we all agree are fantastic for convenience. I run in to get my toothpaste and I say, oh, I'm at CVS, I'll get or Walgreens or whatever your provider is, I'll get my shot while I'm there, especially if it's not as busy now. So the appointments are, you could do it on your phone right there and get it. That's great, but that's very transactional. I'm not having a conversation with the same person who's filling 8 million prescriptions and doing something else. So the idea of if I have concerns, who do I talk to about it? Vivian, that must be a concern from a sort of health point of view when you're not actually having a conversation about the flu season and the need for it. Forget about how it works with everything else that you're in line to get.
Yeah, and one of the things that we've really tried to do at CDC is to really double down on social media and working with trusted partners, community leaders, people who can reach those individuals, not just a physician or not just someone in the healthcare community, or of course, if you're going to a pharmacy, and I think it was over 1 million more doses of flu vaccine were actually given out last year at pharmacies. And so trying to get that message out from people that communities know, right? Whether you're a pregnant person, whether you're from an urban or a rural location, and also we're starting to get those materials out sooner. So this is going to be the first year where we're actually starting in September, and so all of our communication assets and materials are going to be available in September at the beginning of the month, so we can start getting that message out sooner than later.
Yeah, and that is a change, right?
Yeah, I was just going to comment that the public-private partnership that has to happen in this arena is critical. So we look, even though we're an industry, we look to the CDC for direction. As soon as those materials come out, the most important thing is that there's consistency in the messaging. So we don't come up with our own messaging. We follow the
Well, that's the lesson from COVID, isn't it? The inconsistency or the crossover. And granted, it was happening in real time on a scale that it's never been happened before. So I think it's understandable that that was the case because everyone was learning in real time on the fly. But Andy, this I think is a problem. So there's fatigue, which is one thing, because nobody wants to think about this stuff anymore. We're so over it. There is a part of us that just wants to sort of go enjoy the sunshine and forget this stuff exists. And it's easy to when it's not spreading. But there's another part of it, which is skepticism.
Yep.
And that is a high hurdle to get over, especially, I know as a parent, I'm sitting here thinking, okay, what do I need for my kids? What about me? Is there a sequence? Can I get everything at the same time? Should I get everything at the same time? It's very unclear. Am I getting a COVID vaccine every year? I don't even know. I'm not even sure. And I will plug in and do the work to find out and talk to my provider, but that's not everyone perhaps is in that situation. How can we think about the skepticism part and frankly, the misinformation part
Yep.
that that we know has spread in the vacuum of reliable information?
You know, part of that is sort of science-based. And, you know, I always emphasize, I live in the virology world, and, you know, the vaccines were still performing the way we expected them, but what we didn't realize was the virus changed so quickly and so extensively during this just a couple of years that it was circulating, that it sort of sent the message that maybe the vaccine isn't working. It was really the virus changing and becoming something very, very different from when it first emerged. That's not an easy message to get across to the general public, but it's one of those things that I think now that we're settling into a more routine COVID-19 vaccination. We'll get some more recommendations in the next couple weeks about what's happening in the fall. I think now is a great time to sort of reset everything and understand where we're going with that vaccination strategy, reaffirming the fact that these vaccines are working very well, and now setting the expectations in a way that people would be much more understanding of it. Yeah. You know, those first vaccine studies, 90+% efficacy, even when I saw that, I thought, wow, that is crazy efficient. But there was certainly, that didn't stay as high because the virus then continued to change and get better at infecting people. So now we're settling down into a place where I think the messaging will be a little bit more straightforward and simple. We just have to really sort of double down and make sure that we're communicating effectively that.
Yeah, we were focused on the vaccine when we should have been focused on the nature of the virus. Vivian, is this, that's a really, really good point. And I think because we're not virologists, we all, you know, we see the movies where it morphs all the time and we're concerned, but, you know, we've convinced ourselves that's science fiction. Are viruses getting smarter? Do we have to think about this? I know that when you talked about the animal part, you know, I tend to think, all of us think that somewhere in some developing world country at some animal market that doesn't have anything to do with my life, sitting in a, you know, first world, developed world country, what do we need to understand about the nature of viruses? Because that morphed as quickly as we were moving, and we were breaking things, moving so quickly. That should have been, I think, a shot across the bow for a lot of people.
Yeah, you know, these are all RNA viruses that we're talking about here, and these are viruses that change very quickly. I think we're more used to influenza changing, as I think most people are generally aware that we update the vaccine mostly every year for, again, 3 to 4 viruses that are in that one shot, right? So it's not just a vaccine for one virus, it's for multiple viruses. But when we think about the other side of it, the animal-human interface, a lot of these viruses, before, you know, they're in people, they do come out of the animal population. And so this is the pandemic threat that we are constantly aware of. And we're exercising each year with seasonal flu in people to also be ready for what may change and move out of either the wild bird or swine populations anywhere, but even in the US. It's going to be swine flu season, right? Where there could be a potential pandemic.
So you're talking about two different things. You're talking about the seasonal flu that we're all used to, but you're also talking about using all the lessons learned for the next pandemic. This is not a seasonal flu that we deal with. This is the potential for another type of global pandemic.
Yeah, it's like two spaces.
That's extremely important, and I think when we broadly talk about influenza, we do not think about it that way.
Right, and right now we've had the largest avian flu outbreak in the history in the U.S. of H5 influenza in the avian space, impacting poultry and wild birds. It's global as well, and so this is a space that we have been pretty much leaning into and responding to kind of behind the scenes. It's really good news that we have not had, we only had 1 case in the U.S. in 2022, but globally there have been 13 cases. There was 1 fatality actually in Cambodia, and this was a really good example of where we had people on the ground. We had very strong collaborations in the global space. We work with over 100 countries over the past 20 years to build that capacity so that we had a rapid team that was able to get data quickly on that virus that actually killed a small child, and then also her father was infected as well. So we were really concerned that this was evidence that this avian flu virus was moving from person to person. Turns out they were separate exposure events from sick poultry. So it was not human-to-human transmission. But we were able to get that information within days, not only in the field in Cambodia in collaboration with the Ministry of Health and, again, CDC staff and other collaborating groups there, but also to have our folks in Atlanta help get that information out. And, we're really concerned about, do we have a vaccine? Do we have antivirals? Do we have diagnostics that can detect and pick up this virus should the situation change?
That should be a real wake-up call for all of us. As we wrap up, I would like to, Andy and Dave, for you to both comment on this, because rightly so, we talked about fatigue, we talked about misinformation and kind of coming out of COVID and trying to communicate better. But this is a great example of potentially the infrastructure improvements, the surveillance improvements that we can build on, now being aware of how rapidly you need to identify the problem in order to jump in and get ahead of it. That may be a silver lining that we can build on. Andy?
Absolutely. I think maintaining capacity has really been my mantra over the last couple of months, because we showed how much we could do in the COVID pandemic to keep track of the virus. Those same tools, those resources can be now turned to provide us with a better, broader surveillance in the human population to understand these infections at a deeper level and to get better care to people then, because there are a lot of vaccines, a lot of antivirals out there. Sometimes that data of really capturing how much of an impact a particular virus has on us as a population isn't there. And when we have that data, that gives us one more piece of evidence that we can go to the population and say, look, 40% of you got infected with a particular strain of RSV last year. We should do something about that, and we can do something about that.
And data, as we know, I'm sure it's going to thread through this conversation, is king and can be a really powerful tool. And globally, our ability to globally coordinate, we saw what could happen when everyone was on the same page with COVID. I'm guessing that the challenge is in the last mile, because you were talking about the point of care and getting that information out then through the community. That's something that sounds like where the benefit from infrastructure from COVID is now in place and we can build on it. That last mile is going to be a challenge.
Yeah, it is. And one thing to just highlight, before COVID, everybody was preparing for an influenza pandemic. So the world was, the world's health authorities, CDC, WHO, all of the health authorities around the world were preparing for that. And I would say that we came out of the COVID pandemic better because we had an influenza program on an annual basis. So the infrastructure that was used during the pandemic, the COVID pandemic, was built for influenza.
So some of the rails were there already.
The rails were there, and it was intended to be, you heard the comment that each year is a dry run for a pandemic. So the better we can implement the seasonal program, the better prepared we are, seasonal flu program, the better prepared we are for a pandemic, whether it's influenza or COVID or something else. So I think that last mile of implementation is absolutely critical, because speed is everything at the onset of a pandemic.
And I think underscoring the severity of it, because we do come out of that thinking, okay, well, we were worried about dying in COVID. If we just get the flu, we'll push through. We have a different conversation when it comes to our children, I think. We're on it for them, but as adults, we kind of think, if I've got to make a choice and I've got all these vaccines I have to get. Vivian, it sounds like we need to message on that and the worry that was there before COVID came into our lives.
Yeah, there are antiviral treatments available for influenza. They've been around for quite some time, and early treatment is key, right? So the sooner you get treatment, your symptoms are going to decrease. You're not going to be sick for as long. I'll take those odds. I'll be happy to not be sick for as long with influenza. So yeah, I think getting that message out and making sure that people are aware of the tools and the resources that are available to them from the history that we've had so much for flu is going to be really important.
And one thing on the communication side that we learned from COVID, while, as Andy had mentioned, at the beginning, with the efficacy numbers were fantastic when the vaccines came out, and then the viruses mutated, and the conversation changed to minimizing disease and hospitalization, and it worked very, very effectively. That's something to really transfer to the influenza discussion, because each year we simplify the discussion around the effectiveness of flu vaccine in the context of efficacy. Did it stop? Did it prevent it? Or was there a breakthrough? And those numbers could be somewhat underwhelming. But if you start talking about it, well, even if there was a breakthrough, did it minimize the impact or the hospitalization or the mortality, that's a completely different
Yeah,
conversation.
and much easier to measure as well.
Yeah, and it's a much more important outcome, right? It'd be great if we could stop the disease completely, but if you've come out of it and you've minimized the burden and you've prevented hospitalizations and hopefully some death, that's that's the goal, right?
That is the goal, and it sets the expectations. Well, we're out of time, but I feel like we're all more prepared heading into the fall, as we should be, so thank you all for that.
Thank you.
Please welcome to the stage Foreign Policy Executive Editor Amelia Lester for an interview with the Honorable Ed Markey, U.S. Senator of Massachusetts.
Thanks for coming. I'm delighted to have Senator Markey here. Senator Markey, I'm so glad to be talking to you today about your work promoting mental health amongst young people. That's a topic that's close to my heart. I have 2 children, and it seems like it's an increasingly challenging world to navigate with the COVID-19 pandemic, gun violence, climate change, and of course the prevalence of social media and its largely unknown effects on developing brains. So that's in fact where I want to start. I want to start with social media and with a great quote from you, which really puts into perspective its effects. You've said, big tobacco damages our lungs, big oil damages our environment, big tech damages our young people. How do you think it does that, and what do we still need to know about its effects?
Well, last year in the United States, 1 in 3 teenage girls contemplated suicide. 1 in 10 teenage girls actually attempted suicide. 1 in 5 LGBTQ youth attempted suicide last year in the United States of America. So we have a mental health crisis amongst young people in our nation. During the pandemic, there was a doubling of the amount of time which young people spent online. And we can see that there's a toxic stew here that has been brewed, where young people are now absolutely living in a world of crisis in our country. Much of it is driven by, for the most part, unregulated media. So, for example, if you're a 13 or 14-year-old girl in the United States and you have bulimia or you have anorexia and you go online, your information is going to be gathered. And most likely, you'll start to get targeted with more information about bulimia, anorexia, than you actually wanted to have in the first place, only worsening your condition. What are the rights that 13 or 14-year-old girl, what does she have? She has no rights at all. She can't tell the company to stop targeting her. Her parents can't tell the companies to stop targeting her because she's just become a product of those companies. And that's why we need an online privacy bill of rights for teenagers and children in our country. The right to say that we know that information is being gathered about them. And we need notice that that information that's being gathered is going to be used for purposes other than that which was intended. And the right to say no. And we have to set the standards here in the United States, because our tech companies, they fight regulation overseas. They take the position that they invented it, they can decide what the algorithms are, and you just should stay away from it. But you can't preach temperance from a bar stool. You can't say that the United States has the highest values in the world, and then not yourself maintain them. And the youth crisis that we have in our country is a perfect example, and we need to pass the laws here so that then we can set the example for the rest of the planet in terms of the safeguard, which should be put in place to protect teens and children in our country.
So I have to ask about the Camera Act, which you have authored with Representative Raskin, which directs $15 million for research into how technology is reshaping the development of children. What are the questions that you want this research to answer?
Well, there's never been research done by the National Institutes of Health on the impact of social media on the young people in our country. So I want, for the first time, to have the federal government do the definitive study of what has happened to young people in the United States over the last 20 years since social media has been introduced into the lives of young people in our society. It's never been done. We need the absolute definitive word from our top health care specialists that would then drive what we need to do in order to protect young people from the most pernicious aspects of social media. There's a Dickensian quality to the internet. It's the best of technologies and the worst of technologies simultaneously. It can enable, it can ennoble, it can degrade, it can debase. Yes, we want to reap the benefits, but we have to begin to now eliminate the downside of the internet, because we can see the catastrophic consequences it's having on young people in our society.
And I think there's a sense globally that this is something that needs to start in the US, because the vast majority of these companies are based here. We've seen Europe take some steps towards privacy regulations. I think there's a sense of, why is it taking so long in the US to put these kinds of guardrails in place?
Well, Europe has taken strong steps, but it was fought by the US companies the whole way. That's the shame of it. And the reason that they fight it is that, like, as you said, like the tobacco industry, these industries have to target young people, get them addicted, get them going, so that they're so used to having this product, whether it be tobacco or it be social media in their lives, that they just accept it. So since the Surgeon General, for example, in 1965 issued the warning on smoking, we've gone from 50% of adults down to only 20% who smoke in the United States. And here's one other thing, which tobacco companies know, that if you haven't started smoking by the age of 19, the chances of you starting to smoke is almost zero. So they know they have to get you young.
Yeah.
And the same model has been adopted by the social media companies. They have to get you early. They have to get you addicted. They have to get you into a frame where you're using their product, even though it's having dramatic, deleterious impacts on your brain.
And this is something you've been working on for a while. You authored the landmark Children's Online Privacy Protection Act of 1998, and then before that, you put in place regulations on advertising on TV for children. Obviously, things have changed in the last 25 years since that Children's Online Protection Act. What are some of the protections or regulations, common sense safeguards that you think need to be put in place urgently?
Well, I think that we have to say, number one, that when a social media company, TikTok or Instagram or Facebook, you name it, gets information about young people, they then can't target those young people with advertisements. That is prohibited. We need an eraser button where the young person or their parent can say to the companies, erase all of that information which you have gathered about me or about my child. We just absolutely stop harming my young child in my house. So
these sound like they're going further than Europe. Do you think you can get this done?
I think that actually the hearings on TikTok have helped to make it very clear the impact which social media companies are having on young people in our country. And I will say that while many people talk about banning TikTok, what the TikTok hearings have made clear is that American companies are doing the same thing.
So does TikTok need to be banned, or is that?
No, I'm saying we need a uniform set of regulations across the board for TikTok, for Facebook, for Instagram, for all these companies, just saying, stay away from the young people in our country. Stop using your drive for profits as an excuse to harm the mental health of young people in our society. It's a crisis, just stop it. But we in Congress must pass this law. In the same way, I would say that climate reinforces mental health concerns of young people.
I do want to get to climate.
Well. No, please.
But I do have to ask, so do you think TikTok should be banned?
I think that we have to put guardrails around all social media, all of it, all of it.
So banning TikTok not a priority for you?
The top priority is the harm being done to young people in our society right now. That's the real harm.
Right.
That is something that's a clear and present danger to the health and well-being of our nation right now, and we should pass those safeguards immediately, or else we're going to reap a whirlwind of mental health issues for these individuals for generations to come. We have a chance right now to do something, and if we don't, we're going to see people writing novels and books when they're 35 and 40 saying, what was our society thinking about when they allowed me to be exposed to all of that trash, that crap, you know, that is generated online. So,
do you think that can be a bipartisan thing?
Yes, it is. My legislation is bipartisan. I'm doing it with Senator Bill Cassidy, a Republican, a physician from Louisiana. He understands and is very concerned about the mental health aspects of this problem as well. And by the way, we also have to increase funding for mental health, young people's mental health in our society as well. We have to do that in tandem.
Let's talk quickly about the work that you've done on funding for mental health regarding climate change and the bill that you've put forward that says that there needs to be more mental health support for people in environmental justice communities, communities that are very affected by climate change. That strikes me as a really ambitious goal. Tell me about what are the challenges that are inherent in government working to promote mental health in young people.
Well, this is, the climate crisis is something that young people believe has been left to them to solve by the preceding 2 or 3 generations, and that they did nothing. And that they are now going to have to live with their lives and their children's lives with the consequences of the dereliction of duty which public officials in our country actually engaged in, allowing the fossil fuel industries to control the public health agenda of our nation. And if the United States doesn't lead on climate, then we can't expect the rest of the world to follow. Again, we're hypocrites if we don't act. You can't preach temperance from a bar stool. You can't expect a child to not smoke if you have a cigarette while you're telling them smoking is dangerous. You can't expect a child not to drink if you have a beer in your hand while you're telling a child that alcohol is bad for you. And you can't expect the rest of the world to listen to us if we preach temperance on climate change and we continue to pollute. Okay, so young people are smart. They can see the hypocrisy. They expect us to act, and they live then with the mental health consequences of all of the threats, all of the dangers, and at the top of the list are environmental justice communities, Black, brown, immigrant communities, which have always been the sacrificial zones in our society, in the same way, by the way, that poor countries around the world have been sacrificial zones in terms of environmental damage as well. And so young people see it. They're calling out the hypocrisy.
What inspired you to work on this? Was there a personal story here?
When I was a boy, I lived in the sacrificial ward in Malden, Massachusetts, where all the industries were along the Malden River. And when I was about 10, my mother said, Eddie, whatever you do, don't swim in the Malden River, 3 blocks from my house, where all the chemical and coal and other companies were just using the Malden River as a dumping ground. And And the Malden River was black with a pre-Jimi Hendrix purple haze over it. And when your mother says, don't swim in the Malden River, you know you're not Tom Sawyer and Huckleberry Finn on Mississippi. You're living in an environmental sacrifice zone. It didn't have that name at that time, but they exist in every city in America, and they're always in the poorest wards, okay? And around the world, it's always the poorest countries that are the environmental sacrifice zones, okay? Young people know this, not only here, but around the world. And the United States has to be the moral and political and technological leader to solve this problem. And that's why the global conference that's coming up in this November is really going to be a challenge for our country, because the rest of the world is going to be saying to us, what are you doing? And thank God, President Biden last year signed the first major climate bill in American history, but we have so much more to do in order to satisfy the very real concerns young people have about the kind of lives they will be leading.
Well, best of luck with that fight, and thank you so much for joining us here today.
Thank you, and thanks for having this subject. Very much appreciate it. Thank you.
At this time, we'll take a short break. The program will continue soon. Ladies and gentlemen, please take your seats. The program will begin in 1 minute. Please welcome Maggie Lake, veteran journalist and founder of Maggie Lake Media, to the stage for an interview with Sarah Vogel, Senior Vice President of Healthy Communities with the Environmental Defense Fund.
Hi, everyone. You can keep getting your coffee, keep yourself fortified, and getting your food. We're going to start. We're trying to keep it on time. But while you're doing that, I'd like everyone to just take a moment when you walked in and think about your journey in this morning. And I don't know about you, but I woke up and it was beautiful. And I thought, wow, this is a sort of a perfect June day. And then I immediately exhaled a sigh of relief, given where we all were last week. And I think I still have a scratchy throat because of it. And I couldn't think of a more timely conversation to have with you because of that, because I know you look at the intersection of climate and health. I think for many of us, those were separate conversations until a week ago when it literally strangled us and became front of mind in the headlines for everyone. So let's just kick off. Talk to me a little bit about what we need to understand about that nexus and intersection.
Yeah. Well, I am grateful that the air is clean today, but I think we all did experience those horrific air quality days last week. So let's just talk about that event, because it's an unfortunate illustrative example of the relationship between climate and health, right? So across the eastern seaboard, right, we saw tremendous air pollution over the course of about 3 days, historic levels in New York City. They'd never recorded such high levels. And of course, that was due to wildfires burning mainly in eastern Canada, but also in the west. So climate change, let's just connect the dots, just do that simple kind of connecting the dots, right? Climate change is resulting in higher global temperatures, right? That's pulling more moisture from the ground, it's holding more moisture, right? So you get extreme weather events, you get these intense rainfalls, and then you get drought conditions. So in that situation of a more dry condition across forests of Canada, right? That's great. A great environment for the inevitable wildfire. So we, in fact, are seeing wildfire season longer. We're seeing much more severe fires, and these intense fires burn so hot that the plumes of smoke can go very high up into kind of the free troposphere and travel long distances. So if you lived in Washington or New York, we actually experienced this last summer too, around July. Really bad air quality again. You might have noticed the sun was kind of this deep orange. So now we're all exposed to unhealthy levels of air pollution, and that means that climate change basically is exacerbating already an environmental risk, which is air pollution. Now, fortunately, in the US, we've had pretty clean air thanks to a lot of work of the Clean Air Act. But in other parts of the world, air pollution is a significant health crisis. So climate change and wildfires are, this problem of wildfires is happening on every continent except Antarctica. Wildfires is then magnifying this problem of air pollution, right? So it's degrading air quality. We're also seeing that rising temperatures can contribute to more ozone, so that can also degrade your air quality. But that's the connection. And then what we know about air pollution, now there's a lot more to learn about wildfire smoke and health, but we know a lot about air pollution and health. We know right now, in fact, that global air quality or air pollution is the 4th leading cause of premature death globally. It's the 4th leading cause. And that's due to lung and heart disease. So these are causal linkages. So think of stroke, heart attack, lung cancer, COPD, asthma, early premature birth, neurological and cognitive problems. It essentially affects almost every part of your body. Yes. And the reality is that there are millions and millions of people around the world every day that are breathing incredibly poor air.
So how are you tackling this? Because as you pointed out, because of the fire situation, a lot of us are much more conscious of it, but air quality issues have existed. So how are you thinking about attacking the problem?
So at Environmental Defense Fund, we started, we've been working on air quality forever
Years,
and ever and ever. But over the past almost decade, we've started this global clean air initiative. And basically what we are trying to do is leverage a lot of the advancements in new sensing technologies and the ability to understand air pollution, to take that data and to drive it into clean air and climate actions. So there's a lot to that, but so maybe I'll tell you a little bit about.
Yeah, it strikes me that there's a saying across sort of the finance world and private sector: if you can measure it, you can manage it.
Exactly.
Right?
Yes.
But it's the measuring part of it. So it's interesting to me now with advancements in technology. I think we all know that. By the way, I don't know, you probably all realize my phone was dinging and my watch constantly saying air quality alert, air quality alert. So I think we're feeling that technology. So what does that mean on the ground? What are some of the things that you're doing?
So in the United States, the reason we've been able to have good air quality, right, is we have a pretty decent network of air monitors. But if you look globally, it's skewed, not surprisingly, right? We understand air pollution in parts of Europe and the US, and then when you start getting outside of that, it's pretty sparse. So enter in, lower cost sensors, satellite technology. Suddenly, you can start to understand air pollution at a global scale, and you can start to understand pollution at that scale of where we kind of live, work, and play, right? So the way the technology had been before is we would understand pollution at kind of this coarse, granular level. For example, with the smoke, big picture. So, which is great because it moves across boundaries and you need to understand that. But what's been amazing, particularly out west, because there's a real density of private networks of sensors, is that people could see the different levels right across within a city, which before you would have maybe one point of understanding. Okay, here's the air quality. But air quality across where we live, and most of the world lives in these big urban areas, is really, it varies. So
I don't think people probably realize that. So give us an example of how that sort of localized micro look.
Yeah. So we entered this space, again, about 10 years ago, and it was a bit of the Wild West. Like, people had sensors going everywhere, and no one really knew, well, what's the quality of the data? Could you actually measure air pollution at this neighborhood scale? And so we brought a bunch of different partners together, including Google Earth Outreach, who were interested in using the Street View car as a mobile platform, and academic partners and community leaders to say, can we understand pollution at this block by block level? And we took millions of measurements.
In California?
In California, and now we've done this in many other parts of the world. And in fact, you can. And what we found in that first study in Oakland, California, was that pollution can vary up to like 8 times in a single city block. And so then we asked this question, well, okay, if it's varying that way, does it actually matter for your health? And so then we partnered with Kaiser Permanente to get access to data, health data that would be that refined as well. And in fact saw that, you know, if you were living in one of these hotspots as an elderly person, so you're already vulnerable, you had a significant increased risk for cardiovascular events. So that information, this kind of very localized information, was used by the community leaders to design what is called a community air pollution reduction plan within the state of California. So they could use that information to say, in these highly impacted regions for air pollution, here are the activities that we could take to reduce.
So this is amazing because it sounds like it's creating, as I listen to you, almost like a heat map, like a 3D heat map, because you're no longer just looking at isolated data sets. You're marrying them together so you can actually see an accurate sort of living portrait of where the pollution is on a local level, but importantly, what it's doing. So it seems like that was maybe what was missing, what's been missing in the conversation with climate and health.
Yeah, that's right. I mean, I think there are 2 important factors. One, which is the advancements in environmental monitoring, including the satellite data, right? And there's so much data coming and already coming around greenhouse gas emissions and methane and air pollutants. So having that granularity at a spatial scale and a temporal scale, so you could actually understand what does air pollution, what's the actual experience as we breathe it in, right? But then what we've been pushing more is that you have to then marry that with the health data, underlying health data, and socioeconomic data, understanding those underlying vulnerabilities of the population that's then exposed to the air pollution. Because if you just understand the concentration of pollution and you don't think about who's breathing it in, you don't know who's most impacted in a given area. And that's really important if you want to target your policies to deliver the biggest health benefits through reducing that pollution. So you could just reduce the pollution and you would just have a change in the overall concentration of the pollutant, but you might not be getting at the people that are most vulnerable to that pollution. And that's a really important piece.
It is. It sounds like it's also, because not only are you trying to use it as a prescription to make changes that improve the air quality, potentially you're also talking about resource deployment, protection, and equity in terms of planning. So this is a very sort of, the local data does it make it easier for solutions to come up, to create solutions for?
Well, so it's interesting you said you can't manage what you can't measure, right? I think with when you have all this data and increasingly big sets of data, right, it's really important to ask ourselves, what questions do we want to ask of the data and why? Why are we asking those questions? So this comes into the equity point, right? Do we want to design our policies so that we are actually reducing the health burden of a greenhouse gas emission and what we call kind of health harming pollutant, which are not always the same, but can be emitted at the same time? How do we design those policies, not just to reduce those emissions, but have the greatest impact on those communities that are most at risk? Because the thing with climate change, right, is it functions as a threat magnifier. So you've got all these underlying health risks in a community, right? And then suddenly climate change comes and just blows that up. Like wildfires on a community that maybe already experience high levels of air pollution. And we know that in that distribution of air pollution, it's not equitably distributed, right? So you think about the relationship between how we have set up our housing structure, our transportation infrastructure, a lot of deep systemic racism in those policies that have resulted in what we're seeing today, which is that Black and brown communities in the United States are more heavily exposed to air pollution. And that is often detached from socioeconomic status. So if we are going to tackle the health equity component of climate change and air pollution, we have to understand that underlying population in order to get to that great policy design where we're not just, saving the planet for a limited few, but for everyone.
Right. And there are costs associated with all of this. So if you're able to target the vulnerabilities, you're also, the flip side of that is you're targeting your greatest cost output in terms of spending on the diseases that come from that. I love the idea of the localized solutions. Are they scalable? Is this approach scalable?
Yeah. It's a great question, and we've wrestled with this a lot because we've begun projects in the United States. So we started in California, and then we've worked in Houston and Salt Lake, and we did similar work in London, and now we have some smaller projects in India and Latin America. And the question is, there's so much need on the ground. How do you scale? And so one project I'm really excited about is in Latin America, and we're asking this very question. How do you scale? So we've brought a lot of diverse stakeholders to the table to develop solutions at a regional scale. So it's locally informed by bringing really, kind of different partners who are on the ground, but then they're collaborating across the region to say, oh, we all have this common problem. Can we go and secure resources collectively to deal with this issue?
Yeah, well, that's important, right? Because now you're funding a larger product.
Right. Yeah.
That then feeds down. And I'm assuming the best practices kick up on what's working and not working on that localized level, and information that could change.
So much sharing of knowledge. I mean, this air pollution space, it's incredible how much demand and need for technical assistance and resources to tackle this problem, particularly, as I said, in most parts of the world where this is a huge health crisis. And by bringing people together to actually say, we have these solutions, we're ready to go. If you're a development agency or private sector, we're trying to marry those two up to say, okay, here's the need, here are the resources, let's get moving at the local scale, region, horizontal collaboration, vertical collaboration.
Well, believe it or not, we're almost out of time, but I think that let's end on that point because it seems to me that this is an intersection where partnership is everything and everyone has the need. It solves for the need and the problem people have. But it's only going to work. What would you like to see happen in terms of that?
So just two quick points. One is that I firmly believe that there's so much hope in a lot of the advancements in the technologies as we talked about. But we absolutely have to marry that with deep, deep collaboration. And that takes a whole set of skill sets. The two have to come together. Again, you have to know what to ask for. And so that to me is a huge piece. If we want to develop successful inclusive policies, we have to do that in this deep inclusive way.
Yeah. Surveillance alone isn't enough.
It's a nice shiny toy, but it's
there's a saying in AI, garbage in, garbage out, right? So you have to have the right, you have to be asking the right question.
Exactly. And the solutions are there. I think that's the other piece. I mean, wildfires is going to be a challenge. There's a whole set of, kind of solutions there, but air pollution is a solvable problem. We've done it before. So we could make huge, huge health benefits.
Well, we're going to end on that optimistic note. I feel like we just began to scratch the surface, so please feel free to follow up afterwards because there's a lot of good information out there.
Yeah,
thank you so much.
Thank you.
And now, please welcome Jennifer Pope, Vice President of Sexual and Reproductive Health, HIV, and TB for PSI Global, Byron Austin, Executive Director of Corporate Responsibility and ESG Management with Oregon, and Dr. Samokaliso Dube, Director of FP 2030. This conversation on closing gaps in women's health will be moderated by Dr. Maisha Alam, Vice President of Research for FP Analytics with Foreign Policy.
Hi, everybody, and thank you so much for being here. I'm really excited to have this discussion on a really important topic, women's health, with such an illustrious set of panelists. So let's dive right in. Samu Kaliso, I'm going to actually begin with you. As Executive Director of FP 2030, your organization has been at the forefront of a rights-based approach to family planning. So can you tell us, how does FP 2030 view women's rights from a human rights perspective? And how does this perspective shape your approach to women's health across the different stages of a woman's life?
Thank you very much, and good afternoon, everybody. Just glad for this opportunity as FP 2030 to be part of this panel. FP 2030 is the only global partnership that is focused solely on family planning within the broader women's rights, reproductive health framework. We are founded from the principle that everyone, every woman, every young person, every person everywhere in the world has a right to determine if, when, and with whom they want to have children. And that is fundamental to human rights. So we believe that women's rights should equally be framed within the broader human rights agenda, because fundamentally, women are also human, and that for us is important. Having a right to control your own fertility as a person and make your own decisions about whether you want to have children, and regardless of your partnership status, regardless of your age, where you come from, your socioeconomic status, and even your identity, is fundamental to what we believe in as FP 2030. Now, I believe also there is a powerful link that we have made as an organization between access to voluntary modern contraception and other human rights that you have seen as we are advancing the Sustainable Development Agenda. But this particular link, we need to somehow action it. And this is obviously a link to gender equality. First, we start with a link to health, because we believe that access to family planning, to modern contraception, actually would do more for women's health in general, for maternal mortality reduction, for neonatal and child mortality reduction, and that is important. But also we have seen that giving a woman the ability to determine if and when she wants to have children could be a deciding factor whether she could finish her education, have access to college or even finish college, have access to a job or even hold a job. It makes sense, right? Women cannot stay in school or participate in the workforce or even provide for their families in the way they would like if they do not have time and space in their pregnancies. As a collective, we are not able to make progress on these other human rights markers that we are all espousing to if we do not make progress on family planning. And that is why family planning must sit at the very center of the development agenda. And my colleagues in the panel would attest that there is also a need for us to make sure we work together and cut across different care streams of work if we are to make this goal a reality. And you know what? It may sound simple as I speak about it, but when we have and we espouse towards integrated, people-centered healthcare, that would actually make the single greatest impact on women's health, which is just broader than sexual health and reproductive rights. We know that when a woman is pregnant, it actually would affect even some of the comorbidities that she may have, cardiovascular morbidities, or even some of the metabolic disorders. So we know that the ability to decide around your pregnancy is important for other health indicators and even global health systems overall. That's why we believe that family planning is key. And lastly, it starts well before you attend the clinic. It's the whole ecosystem around a woman's life. As we start in the whole girl effect, I'm sure you've seen that video, or the life cycle of a woman when she was young, when she needs to actually take care of her children, or if she wants to go back to work, or if she wants to finish college, etc. That whole system, we need to program it better. With my colleagues here from PSI, Organon, they are advancing some of these products. It starts well before the clinic. Donors, policymakers, private sector, NGOs, and everyone who works in this space, we need to work together to make sure that we disintegrate these silos and ensure that we provide comprehensive women's health package. And at the core of that, there is family planning. So that's how and why we're at the forefront of a rights-based approach, which is the ability to choose and decide about your own fertility.
Thank you for that. And I think there's so much there to unpack, whether that's about healthcare over the course of a woman's life, primary health, the social and economic aspects. And I'd love to bring our fellow panelists into this conversation to pick up on some of those themes. And Jen, I'm going to turn to you next. Can you help us understand what consumer-powered healthcare looks like in the context of women's health? And how does PSI Global design and implement programs with a woman-centric approach? Are there any examples that you can share or best practices to help people make sense of those concepts and what they look like in practice?
Great. Yeah, no, thank you. And thank you, Dr. Dubé. Everything you said really resonates. I think when we think of consumer-powered healthcare, it's really putting her at the center and understanding her needs, which requires us to listen. Often, over time, programs are designed thinking we know what's best. And how do we really listen to what are her needs, what are her challenges, looking at her whole self? And it's putting the power in her hands so that she has agency, choice, and voice to make her own decisions. And so as we listen and include them in women in programming what they need, it's thinking about how do we flip the health system to really work for her? What's needed? And so that means we might have to expand and innovate of how we're reaching her so that care is designed based on what she needs across her life course, not just for family planning, but across the sexual reproductive health continuum, maternal health, or what have you, and really thinking about what are the needs that each person has in the different segments, because each person is different and there could be different stigma associated if you think about youth, for instance, and accessing sexual reproductive health. And so we really work with the different people with whom we want to make sure the system is serving. And part of that is thinking through, for instance, with COVID, we saw how fragile the health system was, and thinking about how do we expand what we mean by the health system? How do we have meaningful engagement with the private sector? Because we know that a lot of people access their care through the private sector. And how do we deliver public health goals through that? And think about even self-managed care and what that means and how we leverage digital tools to really strengthen that entire ecosystem. But I think when we come back to consumer-powered healthcare, it's also thinking about how do we hear her voice? What feedback are we getting? How do we ensure empathetic care? And the workforce is really responsive to her needs and the system. And so for us at PSI, we have goals of reaching 100 million users by 2030 in partnership with FP 2030 and other partners like Organon. And it really, in order to do that, we need partnership. And partnership starts with her and involving her in the programming.
I love that, and I think it's a perfect segue to my next question, this idea of empathetic care, what that looks like, and what that looks like with partnership at the core. So Byron, I'm gonna go to you next. And from your perspective as Executive Director of Corporate Responsibility and ESG Management at Organon, what's the role of the private sector, whether as a commodity, information, service provider, when it comes to women's health? And where do you see the private sector contributing to the broader goal of equitable health care for women?
Absolutely. No, thank you for having me at this great conversation. And I think Jen and Dr. Dubé said it very well, that it's about putting women at the center and listening to women. Organon is a global pharmaceutical company focused on women's health. We were founded through a spinoff of Merck, or MSD, in June of 2021. So we just celebrated our second birthday. And we were founded on a promise that 4 billion women and girls can achieve their promise through better health. And we really started out on that journey by listening to women, not only their doctors, but also women themselves. And hearing what are their health needs, what are the areas for for more investment along a woman's lifespan, and not only in contraception, which is very near and dear to our hearts. We have a contraceptive, long-acting, reversible contraceptive product, but also in areas such as preterm labor, postpartum hemorrhage, endometriosis, menopause. And this is all, we learned this through clinical research, but we also learned it by just talking to women around what are the different challenges that they face from a health perspective. But focusing on family planning, which both Jen and Dr. Dubé said very well, it really is the center of everything. And it really inspired us to also make a commitment to FA 2030 of reaching 100 million women with our contraceptive products by 2030. And I'm happy to announce that we're actually almost halfway there by reaching 47 million women last year. And so we really believe that it is important to meet women where they are, and that is really, if they show up in the public sector, if they show up in the private sector, where in many countries, in many low-income countries, they access care through private providers for whatever reason, because of stigma of the public health sector, or some idea of confidentiality in the private sector for whatever reason. And so we want to make sure that our products and our services are there wherever she may be. And I think it goes back down to consumer-centric care. It really is about where do they want to access care, given their local geographies, given where they feel most comfortable. And so we're really excited to work in partners with PSI, with FA 2030, with many NGOs, with other private sector companies, with governments, to make sure that not only are we providing care, but also that women's healthcare stays on the political agenda. And that's when we work with governments around the world to make sure that they're allocating the necessary resources and funds to help women thrive, because we know when women thrive, economies thrive.
Well, I couldn't have picked a better transition to what was going to be my next question, and in particular, picking up on these ideas of women's health on the political agenda and the relationship to the economy. And this is a question for all of you, and maybe Samu will go to you first, but investments in women's health impact not only their well-being, but that of society writ large and the economies in which they live, at the local level, at the national level, and beyond. There's extensive evidence and research to demonstrate that. Can you help us understand how investments in women's health specifically contribute to broader economic prosperity? How do we ensure that the impact is scaled up, and that what women want and need in terms of healthcare stays on the political agenda? So Samu, maybe we'll go to you first and then come back to the other panelists.
Thank you very much for that question. And you are spot on. We know that if you invest in healthcare in general, you will achieve economic prosperity. That iteration, whether it's through some of the seminal papers from people like Jeffrey Sachs, etc., we know that investment in health actually contributes more to the economy. But how about women's health specifically? So there are many institutions that are working around family planning, reproductive health, that are articulating that economic equation, and successfully so. We know that there is evidence that if you invest so much in family planning, you get it back, a return on investment for maternal health and for some of the human development indicators at a country level. Our job as FP 2030 is to ensure that not only does this stay high on the political agenda, but that in any other global initiative, for example, we're looking at universal health coverage, we are looking at the ICPD mechanisms, we are looking at even some of the work that we are doing on the sidelines with McKinsey, etc., around investments. What is that investment case that needs to happen at a country level for us to achieve some of these goals? We are doing that on the sidelines to make sure that for governments in Africa, in Asia, they do allocate specific investments for women's health. Now, the challenge that we are having is when you say women's health, it becomes broad, right? For some of us, it can be easy to articulate it as family planning, reproductive health, etc. But it can actually be broader than that. It could be how women, are affected by arthritis, different from men, by cardiovascular diseases. Is it different from men? But if we actually circumscribe it and just say, this is what it contains for FP 2030, we are a global movement. And our way of work is to get countries to make an FP 2030 commitment that ensures that the family planning and reproductive health agenda stays firmly on the political agenda. These commitments are signed by presidents, and we are trying to do right now some peer-to-peer influence by getting some of the presidents in Africa to actually influence each other around these investments. We've got a global collective that actually ensures that, exemplars in doing this better are amplified at a global level. And there are some initiatives that, Dr. Maria, about, like universal health coverage, to make sure that as these initiatives accelerate, family planning and women's health is actually costed and it's included in these agendas. We do that by working with civil society, focal point structures at a country level, and having our champions all over the world. Global FP 2030 is global, working with presidents in Africa, and we're trying initiatives with football players. We're trying initiatives at a global level, but governments are now sort of conscious that investing in women's health will have tangible translation in economic growth.
Thank you for that. And let me see, Jen and Byron, if you'd like to add anything to that from your perspectives as well.
Sure, I think we can't achieve the Sustainable Development Goals if women's health isn't taken as a priority, and that we have comprehensive care and access to services across the continuum of what she needs. We can't pick certain parts and not, because she's a whole self. And I think we've found a lot in our work with PSI, for instance, we work a lot with adolescents and youth. And quite frankly, if you ask them what are they concerned about, health isn't the top priority, but they're thinking about how do I get access to school, continued schooling, or financial sustainability, or different skills. And so we work in a lot of our programs of integrating those programs and showcasing that actually access to contraception, strong health is one pathway to better opportunities in terms of education, or teaching them different skills so that they understand that there's a path that's maybe different or in their dreams. And I think, it's really critical that we look across the board in terms of how we're investing, how we're better integrating in different ministries of health and ministries of planning and youth, and across the board of coming really together and say, this is helping, what do we need as a country? What is the support that we can get? And what are those innovations that will help us achieve that? And I think going back often, women are the cornerstone to anything in the development. If their needs aren't being served, we're not going to be able to reach, economic prosperity, development goals, and, the broader universal health coverage. And so I think it's really critical that we think through that and continue to advocate and support women and listen, most importantly, to what they need.
And I just add to that from a private sector, from a business perspective, women are customers. There's a lot of, it's not only the right thing to do, there's a lot of money to be made. And there's been they're not just beneficiaries, they are customers, and that they should be listened to as consumers. And so we've been working with not only governments, but other private sector players to say, invest in women, because there's an economic case to be made for your own benefit, for the benefit of your own country's economy, and in doing so, that we're going to expand the pie, right? We're going to hopefully get more dollars into research and development, and we've been having these conversations with investors who not all investors have woke up to the fact that half the world is sidelined in terms of a consumer base. And so we're really hoping to change that narrative.
I love that point. Seeing women not just as beneficiaries, but indeed their agency, their purchasing power, and their decision-making power as well are really, really fantastic points. Before we wrap up, I want to pick up on a couple of threads that actually each of you highlighted. For example, Jen, earlier you were talking about the SDGs, the Sustainable Development Goals. And we know that Goal 3 on health and Goal 5 on gender equality are inextricably linked. point. Earlier, Samu, you were talking about the fact that this isn't just about reproductive health. Yes, that's absolutely central, but it's everything from non-communicable diseases to how we get to universal health coverage. And this is something that my team at FP Analytics, the Independent Research Division of Foreign Policy, has done quite a bit of work on as well. And so as a final question to all of you, let me ask you this. With the UN's high-level meeting on universal health coverage planned for later this year, and knowing that this is on the agenda of the UN General Assembly, that it was on the agenda of the World Health Assembly, could you elaborate on the broader context of your ongoing work? And specifically, how does the pursuit of UHC relate to and integrate into women's health? Can you explain that relationship and why those two are mutual goals?
Thank you, Amalia. Can I start?
Yes,
just
please.
kicking us off. First, just applauding everyone who has been involved in pushing for universal health coverage at a country level, at a regional level, and at a global level. Because for us, we know that this is a measure of the world's commitment to ensuring good health and well-being for all. That's SDG 3. That is good. But healthcare cannot be universal if it doesn't include family planning. And too often, many of the UHC schemes do not. And that is a challenge because if you do not, as you said, I think it was in the previous panel, if you cannot measure it, often it may not be done. So we believe that for UHC, if you don't cost it and articulate what it is and make sure it's included in the benefit plan or in the payment plan of a country, it may not happen. So let's make sure as we pursue universal health coverage, we are not leaving women again paying out of pocket for family planning because we know that, as Byron was saying, they are customers, but often they pay for their own family planning commodities. And I'm talking even UHC from a private sector perspective, where many of the health plans do not cover family planning. And yet when we cost it and we include the return on investment for that particular plan, we could gain more from UHC. So that is a warning. FP 2030 is working alongside many of our partners in program development, in advocacy and private sector to make sure we can have strong UHC commitment and structures that include family planning. And often it's not a lot of money to include for that pooled mechanism. You can include just a little amount and you find that you can cover more women with family planning. So we make sure that we don't marginalize women's healthcare needs as we advance universal health coverage. And again, the most important piece of this is the need to integrate care streams and scale up evidence practices with a proven success rate. One such success story is integrating family planning with routine childhood immunization or integrating family planning with postpartum family planning. You know, those are proven high impact practices that we could cost in universal health coverage and scale up in many countries. You know, Malia, the data shows that most women in the year after birth, when they give birth, they want to delay or avoid another pregnancy. But many are not using a modern contraceptive methods. As we are conducting some of the studies or accelerating plans for UHC, when women come back for routine postnatal care or immunizations for their babies, it's an opportune moment to counsel them on family planning options, but also to make sure that these are available. And lastly, we need as a field to integrate family planning with immunization, which has had only positive or even neutral impact on immunization uptake. It's important for us to do that because it doesn't affect the other sector. It has a positive impact on family planning uptake. And we are also seeing some great exemplars from Rwanda, for example, where 98% of women that were interviewed in one study supported the idea of integrating family planning service components into routine immunization services. And again, we need to do the same for postpartum family planning, where we are seeing countries like Rwanda, like Zimbabwe being exemplars in integrating this care. Now, it makes sense. No one wants to go to multiple facilities, multiple clinics, multiple pockets of funding. We need to integrate this with universal health coverage, and we look forward to working with many of you in the room as you advance this important global goal to integrate family planning within. Thank you, Malia.
Well, thank you for that. indeed that clarion call. And I know we're out of time, but let me just see if Jen and Byron, if there was anything else you wanted to add about this issue.
Yeah, I'll just say quickly, building on what Dr. Dubé said, is that when we're thinking of health systems, they have to be responsive to her needs. And so we should incentivize those health systems to listen to her, to ensure that they have dignified care and empathetic care, and that they are really delivering on her needs based on her feedback.
And I'll just add that from a private sector perspective, making sure that when players such as FP 2030 and PSI are working on the demand side, that we on the supply side make sure that she has access to products and commodities, so that that health systems are strengthened and that she can receive care when and where she wants it, and that she has options when she gets there.
Fantastic. Well, Samu, Jen, Byron, thank you so much for joining us and for all the work that you're doing on this issue and will continue to do. Thank you, everybody.
Thank you.
Please welcome back to the stage Foreign Policy Executive Vice President Allison Carlson for an interview with Dr. David Walton, the U.S. Global Malaria Coordinator for the President's Malaria Initiative at the U.S. Agency for International Development.
Dr. Walton, thank you so much for joining us today. We're really excited about this. So to start off our conversation and just to level set a little bit, as the coordinator of the President's Malaria Initiative, could you provide us a brief overview? What is the status of malaria globally at the moment, and what are some key points that are underappreciated or not well understood?
Great question, and I would love to. I think it's important to put it in a little bit of historical context. And so if you look from around 2000 to today, and you sort of look at the progress that we've been making in the fight against malaria, from 2000 to about 2015, if you looked at the graph of decreasing deaths, decreasing mortality, decreasing cases globally, just incredible progress, introduction of new tools, countries making huge progress. And then in around 2015, the inflection point of the graph started to flatten out a little bit. And so, we began as a community to sort of say, this is a little bit different. And then COVID happened, and for the first time since those huge gains, we actually took a back step, and cases increased and deaths increased. And so we find ourselves in 2023 in a very precarious and fragile place as it pertains to malaria. And I think there's a couple things to highlight. Number one, if you look at the population in malaria endemic countries in 2000 to 2023, the population's doubled, right? So we have a lot more folks who are at risk of malaria. We have warmer and wetter climates. We have more extreme weather events. And so when you look at events like the floods in Pakistan, or you look at Cyclone Freddy, we have much more malaria in ways that are a bit difficult to predict. We have increasing insecticide resistance, which is commonplace, right? Like we're always chasing the mosquito, and it continues to elude us in innovative ways. And then we have, for the first time since chloroquine, the mainstay of the therapy of treatment for malaria, artemisinin, and those combination therapies, we're seeing resistance. And so, these things are combining to really create significant threats. And I think last but not least, there's a new mosquito that carries malaria coming over from Asia into Africa. And the difference between this mosquito and the other mosquitoes that have been around for a long time is that this mosquito lives in urban environments where most of the transmission happens in rural environments. And this mosquito is much more durable. And so as climate change drives people from the rural sector to the urban sector, and now you have this new mosquito, the threats are quite serious. But allow me to not be overly negative. We have some amazing opportunities on the horizon. Most of you have heard that we have a new vaccine that was approved by the WHO, and that is underway. The supply is a bit small, but things are moving forward. There's a new vaccine on the horizon. Hopefully we'll see that soon. We also, I'm happy to say, thanks to incredible bipartisan support in Congress, PMI is expanding to 3 new countries within sub-Saharan Africa. And then finally, I think along with USAID and PMI, we're really thinking about how do we create more local expertise in malaria and strengthening of that capacity in malaria endemic countries. So really, at the same time that we have a lot to deal with and it's a very fragile time, great cause for optimism.
Yeah, absolutely. And you pick up on our last conversations as well about environmental impacts and these changing dynamics that are increasing the challenge and really requiring multidisciplinary responses to these complex challenges. And you mentioned localization. I'd like to pick up on that as well. I know that's a big focus of USAID and USAID's strategy. So when you think about that and your anti-malaria work, how is that manifesting? How are you reaching communities on the ground? And I know also you've worked on the ground as a physician in Haiti with Ebola. And so when you're thinking about that now as a coordinator, how can you reach those local communities as part of your strategy?
Great question, and it is a good callback to where my career started, really working in solidarity with communities and living in those communities. And I think when we think about localization at the agency level, USAID agency level, and PMI, we're really thinking about how do we change the way our assistance is being distributed, right? And how we really focus on malaria endemic communities and malaria endemic countries. And shifting, as Administrator Power says, shifting the small a agency, that locus of control, over to, from, say, the folks who have traditionally had it, like us, actually, to those folks in these countries who have significant amounts of expertise, but very traditionally limited access to funding sources like USAID and other governmental agencies. And so, we're doing that in a variety of ways. Number one is we're really, as I've noted, trying to shift awards that we make, so funding from from traditional incumbents really to local organizations in these communities. Number two, we're really trying to think about localization as much broader than, say, awards. And so what does that really mean? It means that, for example, how are we shifting and strengthening capacity in these communities? PMI in 2022 alone supported over 100,000 community health workers, which are the linchpin, I think, of our ability collectively, globally, to really make incredible gains in the fight against malaria. When you look at countries across the board who are making significant progress in really decreasing cases and deaths, it is the strength of their community health worker program that largely is contributing. It's multifactorial, obviously, but that's a significant component. Secondly, I alluded to or mentioned drug resistance. As we think about drug resistance, it's really important to understand where your resistance is, right? Where is the drug resistance happening? And so traditionally, PMI has been integral in collecting those samples and then sending them to the CDC, right? Because PMI is an interagency collaboration between USAID and CDC. And the CDC is an absolute essential partner of ours. And so we would take all those samples from Africa, shift them all the way over to Atlanta. And yet, we realize and understand there is significant and robust expertise and scientists and amazing labs on the continent. And so how do we shift that focus? It decreased costs, but in fact, it puts the agency and small a agency and expertise where the diseases really are. And so that's yet another example. And so there's many others, for example, really shifting our support, say in Zanzibar, for indoor residual spraying, which is spraying the walls of homes with insecticides. So when the mosquitoes land there, they die. It decreases the ability for transmission indoors. Shifting that fully from what we were doing it as PMI to fully shifting that to being really operated and owned by the government of Zanzibar, right? And they're doing an incredible job. And so these are the things that we're trying to do slowly but surely over time, because again, this is going to take a significant change in how we do things, but we see this as really the trajectory as we move forward of how we're going to shift the focus to these and expertise to these malaria endemic countries.
If I can pick up on a few things that you mentioned. When you mentioned anti-malarial drug resistance, I know drug resistance in general is a growing concern, and your efforts to understand the impact, collect data, as you said, share it with the CDC. How is that data and information then being shared with regional governments, local communities, so that those decisions and that planning can be more evidence-based and data-informed?
Excellent. And so it gets to actually how we work, PMI works with our partner countries. We work essentially, the core way in which we work is we are fully and often embedded within the Ministry of Health, more specifically the national malaria programs, which every Ministry of Health has when they have malaria that is endemic in their country. And so we sit with them, we work with them, we're in lockstep with them, and we see our role as being able to accompany their journey, right? And to support and buttress their efforts with our funding, with our expertise, both from USAID and from CDC, and again, working with our implementing partners and with our local partners on the ground. And so, you know, the data that we collect, specifically on anti-malarial drug resistance, you know, we are guided by and informing the ministry, you know, really sort of in real time and working with them. And so, and again, this is part of the shift to say, for example, in Senegal, we're able to shift all of that work to the labs in Senegal. So there's no shipping or sort of, you know, having to sort of coordinate. It reduces the burden. It reduces so many of the things that I think can get in the way of our ability to actually be effective in the fight against malaria. So it's incredibly exciting as we look forward in terms of where we're going in the fight against malaria.
So to that end, PMI is in 24 countries in sub-Saharan Africa, 3 programs Southeast Asia, and as you said, you're working directly with governments. And so for those who are here today and those joining us online, what would you say are some of the, I guess, lessons learned about ways to work effectively with governments and make those connections and entry points? I think we're really focused on building those bridges and those connections so there can be greater understanding, data sharing, et cetera, on those solutions. So what are some of those effective lessons learned?
I think some of the most important lessons learned that we have are, I think, understanding that we have a significant amount of expertise and a skill set. And again, part of being embedded within those ministries is to say, inform us, let us know, what is the support that you need? How are we going to help you level up, as it were, to be able to, because that's what our role is, really to sort of buttress their ability to do this. What are the things that you need, both in the short term, medium term, and long term? And what are the tools that we have in our toolkit, and what is the expertise that we have, and funding, to be able to sort of achieve those goals? Again, they're very clear short-term goals, and those are often tactical. And then what does it look like in 10 years' time to have a little bit less of sort of, you know, PMI as steering the ship and more in the passenger seat and not in the driver's seat, right? That's our vision, that's our goal. And so as we work with these governments and these national malaria control programs, we find that is one of the most effective ways to work with them, is really be guided by them as opposed to guiding them.
And I appreciate what you said about it not being just about the crisis response, that you're in it for the long haul and being guided by them. So thank you for your work, and thanks for being here to share your expertise with us, and all the best in the future.
Thank you so much. Really a pleasure.
Next up, Maggie Fox, contributor for the Fuller Project, will take the stage for an interview with Dr. Juan Pablo Uribe, Global Director for Health, Nutrition, and Population, and Director of the Global Financing Facility for Women, Children, and Adolescents with the World Bank Group.
Thanks for being with us, Juan Pablo.
Maggie, thanks to you, and thanks to you all. I'm very happy to be here.
We're going to get right into this because it's an important subject. We're talking about building countries' health systems. How do governments get involved? Everyone you talk to says, you have to get government involved. You have to get government involved. You can't do it without government. How do you get government involved?
I wish I had the solution, but I think they're right. Maybe I would go a little bit further. It's not government. You need to have the governments or the continuum of society of the country owning their own health system strengthening process. You cannot drop a health system top-down in any of our countries. You need to, from the field, from the ground, you need to build the health system that community, that society wants for itself. And it's a long-term journey. That's the complexity, that many times governments get involved, but governments change, ministers change, and you cannot start over and over again, as so many times happens in our countries, because then you will not build that long-term health system that we all desire.
So you were telling me that sometimes there are little inflection points, little opportunities that arise. Can you talk a bit about that?
Yeah, I call them positive accidents. Let me refer to my country, Colombia. In 1991, there was a peace talk with one of the guerrilla groups that opened in society, not in government, in society, a space for a new constitution to bring in the armed forces of the guerrilla and reach peace. And within that window of opportunity that had nothing to do with health, coming out of this new constitution in 1991, there was a space to look at the social sectors. And only because of the momentum of the peace talks behind that, what it meant for society, huge reforms were able to be brought into health, including a health insurance with universal health coverage, focus on the poorest, and also pensions and labor. It's an accident in a way. You cannot plan that, but when it happens, you need to grab it and move forward. And again, this becomes a 30-year journey trying to build, with a lot of hiccups, with a lot of mistakes, with a lot of learning, that better health system that we all want.
How does an organization like the World Bank help sustain that, help glom onto one of those opportunities?
So in the bank, we have in health, nutrition, and population